Subjectivity introduces bias. That's the biggest problem. Bias in particular for women and girls, and that's perhaps the biggest challenge I have with it, is that women and girls are presenting with ADHD differently to your stereotypical bouncing off the wall kid. But clinicians haven't changed all that much. The education of clinicians haven't changed all that much. The assessment procedures haven't changed all that much. The tools haven't changed that much. Capacity hasn't changed all that much. Human brains haven't changed all that much, but what has changed a great deal is the environment. The modern demands of our attention is the biggest we've ever seen, and humans probably didn't evolve to have this huge amount of processing requests and demands at all times.
Welcome to Care Vision's Family Talk, a space dedicated to exploring the challenges of raising children in today's world. I'm Lucy Johnston. Each episode, I chat with a guest and we dive into the real-life struggles faced by children and their carers, offering insights and practical guidance to help families feel understood, supported, and hopeful. Whether you're a parent, foster carer, grandparent, or anyone supporting the young people in your life, this is the place for you. Hello, and welcome to this podcast exploring the biggest questions shaping childhood today. We're entering a remarkable new frontier in mental health. For the first time, advances in science are helping researchers look directly at how the brain functions and differs between people. This could help doctors finally test for and perhaps even treat conditions like attention deficit disorder. So here's a question. Could we one day help identify ADHD by looking at the brain? It sounds like science fiction, but it is a question researchers are beginning to answer, and it couldn't come at a more important time. Hundreds of thousands of families across the UK are waiting months or years for an ADHD diagnosis or assessment, and there's still no single test, no blood test, no brain scan, and no medical test for ADHD, and diagnosis is still relying on medical judgment. My guest today is Dr Monica Bernsten, a practising neuropsychologist who studies how the brain influences a person, and she spent more than a decade working with people with ADHD and autism. Monica is also the founder of a health technology company developing a headset to provide psychiatrists with evidence for ADHD in the brain, and the technology is now entering its first clinical trials. So really exciting time. Monica, are we witnessing the beginning of a new era in mental health care, and could understanding the brain transform the way we assess ADHD or conditions like it? Or do you think the human brain is too complex for such tests?
We are entering a stage of personalized medicine and psychiatry. So that means that we are moving away from more subjective measures of any psychiatric condition, ADHD being the example we're going to talk about today, which you said is heavily subjective, is questionnaire-based, is norms-based, are primarily based on males. And what we know about the brain these days can help highlight and enhance assessments. It's not going to remove the old ways, it's simply going to evolve it into a personalized assessment system. So yes, we can use more objective tests now that will highlight and enhance assessments. It's not going to remove the clinician. It is just going to give them more objective insight. So absolutely, yes. By the way, our company is doing a software, not the headset. So we're not developing the headset. We're developing the software that uses the headset.
Yeah. But why is this important, and why is ADHD such a defining health debate? What's wrong with having a subjective assessment of whether you have it or not? What's going wrong?
That's a very good question. So ADHD, let's take that as an example, is as we think of it now, a behavioral problem. So it is a observable pattern of behavior that causes implications for work, for education, for relationships, for all sorts of things that affects a person's quality of life. The reason we can't just base it on symptoms. It's because it's way more complex than symptoms. One can have attention deficits or hyperactivity profiles without it being ADHD. So our current theory of why ADHD is that it's neurodevelopmental. The brain is basically wired differently. There are other theories available. For example, there's a reward difference theory, there's an adaptive theory, there is a stress response theory, there's an executive function theory. There are a number of different theories as to what ADHD is. I think what is really exciting is thinking about how our understanding of ADHD has changed with the changes in environment, so the context of the society. So when ADHD was first discussed and really thought about was in 1902, so it's a long time ago. That was primarily about hyperactivity, and later that turned into a phrase of minimal brain damage. That's how hyperactive children were classified in 1930s to the 1960s. And a little bit further on from that, attention was brought into the equation, and it was possible to be hyperactive and inattentive, or just inattentive, and that was then called attention deficit disorder. Fast forward a little bit more, then that evolved again as our understanding of brains and behavior evolved, and it was now possible to have one or the other or together. And fast forward a little bit further along, then it was possible to be an adult with ADHD, not just a child, and the symptom threshold was lowered. So part of the problem with that is that the symptom threshold is lower, so more people can fit the criteria, but today what we are lacking is assessment protocols that follow suit with society's changes. So you have loads of modern problems now that you didn't back then in 2013, when the symptoms were reduced and the emphasis were more on having symptoms across different scenarios, different areas of life. You could have few symptoms and still be diagnosed, for example. And the sheer amount of referrals you're getting now for ADHD in particular has gone up way more than there is capacity clinically to see them. Hence, patients are waiting, and the people that have resources to fund them privately, they can do so, but the people who don't, they can't. The subjectivity also introduces bias between clinicians. So you will have some clinicians that interpret the diagnostic criteria in one way that is very different to how others might interpret it. And
what you're saying is that some people, just in simple terms, some people may have a lower bar and, may decide someone has ADHD when someone else may just say, no, I don't think this is.
Yeah, exactly. Subjectivity introduces bias. That's the biggest problem. And bias in particular for women and girls, and that's perhaps the biggest challenge I have with it, is that women and girls are presenting with ADHD differently to your stereotypical bouncing off the wall kid. But clinicians haven't changed all that much. The education of clinicians haven't changed all that much. The assessment procedures haven't changed all that much. The tools haven't changed that much. Capacity hasn't changed all that much. Human brains haven't changed all that much. But what has changed a great deal is the environment. The modern demands of our attention is the biggest we've ever seen. And humans probably didn't evolve to have this huge amount of processing requests and demands at all times.
But if you're saying that ADHD is some pattern, is something inherent in the brain, would that mean that people are able to develop that due to environmental stresses or impacts? So
that's one of the theories.
Sorry?
That's one of the theories. That's the biopsychosocial theory that
do you believe that people are born with it, or that they develop it, or both?
Well, what I believe is that we adapt the best we can to the environment. What you describe is the biopsychosocial theory of why ADHD is there. So it's an integration or an interaction between genetics that you come with, that you are predisposed to in a particular way, and the environment that you're in. So you can have genes that never activate. Equally, you can have genes that do activate if you are in an environment where your predispositions become live. So it's not that easy.
Do you think that this explains why we have an explosion in numbers of people with it? No?
No.
Why do we
have... What has changed is the environment. So biology hasn't changed.
No, I meant, do you think the explosion in numbers is down to the environment, or is it down to the biases in some often criticised, not all of them, private clinicians giving diagnosis, which are setting a bar that's too low or is not accurate? Do you think that part of the reason?
All of the above. Yeah. So first of all, you got a society that is looking for answers for why they feel that they struggle to meet the demands of their life. So say that you have 20 tokens available in mental resources, but your day costs 30, then you're going to run dry pretty quickly. And most people are going to want to look for a reason for why things aren't working out the way that they want or envisage it to work out. Social media plays obviously a big role, because awareness about ADHD and symptoms that you may have, there's also a lot of symptoms that could be relating to lots of other things, not ADHD too. So when you have a platform where everyone, qualified or non-qualified, gets to voice their opinion, you're going to get a lot of variations in interpretations of what symptoms are and what symptoms aren't, right? So it's more interesting to think of it from a environment context. So the biology hasn't changed. Human brains are pretty much what they were 50 years ago. We are seeing more cases now because the environment cost too many tokens, and human brains don't have enough tokens to pay for it. And they are looking for explanations why they can't fit with what they perceive is society's expectations of them.
So talk about those tokens. Is it trauma? Is it anxiety? Is it poor sleep? Is it chronic stress? What is, or are those things that can sometimes look like ADHD but not actually be ADHD?
Yeah. So a lot of the times, the conditioning that a human being experiences from birth to childhood years, to adolescent, to adult changes. So you're conditioned to have a particular operating system, call it that. And that operating system says, if X, do Y. If this goes wrong, this is how you handle it. This happens, this is how you feel. In simplistic terms, that's your personality. It's how you get what you want out of life. It's your strategy for achieving your goals. And that can include bugs that says, if you feel like a failure, pull back instead of work harder. Yeah. So that operating system governs quite a lot of your responses and reactions to the environment. So ADHD can be learned in a way. It depends on the theory that you apply. So some people, some psychologists and researchers believe that ADHD is just an adaptive response to challenging childhoods, challenging environments, which I don't refute at all. It's absolutely possible that you can have an adaptive response to an environment that's too demanding, and this is how you do it. Yeah, but there's also equally possible that a trauma changed the way that your brain functions from a physiological point of view. We know that early childhood stresses, for example, reduces your stress threshold so that it takes less to get you off your balance. So it's really complicated. What is it? Is it a lack of sleep? Yes, it can be. That challenges your cognitive performance. It reduces the amount of mental tokens you have available. So the example, if you carry on with the token economy, then say that you have 100% in a bucket, that's your resources. But about 30% of those resources are going to be given away to keeping you alive, and it's non-negotiable. You can't take those 30%. So you're left with 70% that you can decide where you're going to spend. And say that 70% equals to 20 tokens. And your day costs 20 tokens every day, but you have 25. So you're going to be okay on that basis because you'll do all the things you need to do. You'll sleep and you'll wake up with 20 tokens or 25 tokens again. The problem happens if your environment costs more resources than you have, then you're at a deficit. And because every function in your brain costs resources, it means that if you are spending more resources than you have, you are chronically depleting your resources. And if you don't sleep well, that means you don't replenish the resources that the day before costs, which means that now you may wake up with 18 tokens available. And if the day continues to cost 20, but you only have 18, you are now starting a spiral downwards. Because if you don't sleep well and you don't replenish, but nothing changes, as in the burden around you isn't going to go down, you're just going to continue to spend resources that you don't have, you are going to cause stress to your body and to your mind, induce anxiety, all of which cost resources that takes away from your cognitive functions. And those cognitive functions, executive function, planning, organizing, and the rest of it, can absolutely look like ADHD, but isn't.
Yeah, I mean, one could say, well, that could lead to depression, breakdown, anxiety, many different things. But we'll deal with that in a minute. One thing I was going to ask, we've had wars, we've had the Great Depression, we've had recessions, we've had poverty, we've had all sorts of environmental stresses over decades and centuries. Why is this 21st century particularly stressful and leading to more cases?
Well, again, it's the context of the environment. So never before have there been more burden on people to be good enough. So humans have always been scared of not being good enough because it's evolutionary adaptive. So in the hunter-gatherer days, if there were any signs that people didn't approve or didn't like you, in the human brain that's coded as a kind of a pain that is a threat signal that is almost like equaling to death. So if they don't like you, you might die. So it's very important that people like you. Now, it's very important that they don't dislike you. That's the evolutionary theory. So we haven't really shed that yet. We still have that. If people show signs of disapproval, it might lead to death in human brain terms. Therefore, we work really, really, really hard to avoid people showing any signs of not liking us. So it's not the same as wanting to be liked, but it's actually more about not being disliked. So why that is so important now is because society is broken apart. There is less community, there's less support around, families are broken down, there is less availability of support in the household, children are more and more left to their own devices, in fact spending time on devices, and they are developing very differently to how we have been developing and evolving for the past so many thousand years. So society's changed way quicker than human biology can keep up with. So we don't know how to handle the modern pressures on human psychology. So what is good enough for a human brain now is very different than what it was just 2 decades ago, where it was good enough to have a job and to be a moderately successful person, whereas now that's all very much changed into what you look like and how many people like you on Instagram, and it's become very much on the outside. And I think people, children in particular, feel more and more empty on the inside because of the lack of support, the lack of navigation, the lack of concrete, something that's sound and stable. So it's a world that's become very much abstract, and it's all about the outside, not about feeling safe. And that's the problem.
Yeah, I mean, people were left to their own devices, children were back in the day, but are you saying that they had a network and a community and they felt sort of anchored in some way?
Yeah, it was different. So you would typically have a one working parent household. Not that I'm against 2 parents working, but we got to acknowledge that there's a problem with parents not being around. It is because the way children develop emotional skills, cognitive skills, how to handle themselves, frustrations, and so on, is by interacting with emotionally competent people. And if they only interact with other children, they're not going to develop those skills. So in the past, there would have been a parent more present and available to help them navigate those things, whereas these days, they are spending more time on their own, on devices, interacting with people that are more their age, and therefore they are not failing, but they are developing differently than past generations would have.
But are we perhaps grouping together sort of several different conditions under this label ADHD? Presumably it would manifest in certain ways, but what does it even mean, ADHD?
Well, that depends on which theory you subscribe to. So there's a number of different theories there. My perspective on ADHD is that it's probably a normal variant of how brains have evolved to process attention and engagement and motivation and so on. I don't think it's a disorder, to be honest. I think the problem is that society cannot accommodate or struggles to accommodate variations. Just like I think autism is probably a normal variant that doesn't happen so often as the most predominant neurotypical variant. I think it's just a variant that we had for a long time, probably always, because at some point that variant would have been useful at some stage. So I buy into a bit of the adaptive response as well as the evolutionary theory. I don't think that ADHD is a common problem, as a modern problem. It's become a modern problem because the environment isn't particularly conducive to more psychological safety. It isn't safe out there because there's too much burden and pressure on young people to be what they consider good enough.
Do you think phones, social media, the stimulation, the school pressure, that seems to be a very results-driven system which adds more and more tests and assessments. Do you think that has changed children's brains or their behaviour?
No. I think what's changed is the amount of information processing they are being subjected to. And also the expectations has changed a bit. So they're more expected now to have more sustained attention, to be sitting during, for more times they are expected to take information in and learn. But you have to remember that we have a limited amount of attention resources. So if you spend, say, 5 hours in school, but for the rest of the time, you are bombarded with information that costs resources all the time. Unfortunately, you've got several things going on there. One is that human brains, they want to find comfort and safety, but they also want to be entertained. So they want to find reward. If there isn't much reward sat through a lesson, listening to mathematics or whatever it might be, they are going to go inwards and find more engaging material of their own, or they will generate it by talking or being what we call disruptive, not because they can't pay attention, but because environment is costing more tokens than they have to give. So if we could limit the amount of resources that they spend attention-wise elsewhere, I think that would help the school system a great deal. But you can't put that cat back in the bag or the genie in the bottle. So it is what it is, and we're going to have to evolve to a system that is more balanced and conducive to mental health, because at the moment, in general, there's a mental health crisis where we have more and more children diagnosed with more and more severe disorders. And obviously our thresholds for disorders have changed a bit as they do. The problem is the scale. As the severity's gone up, it's been broadened, but the sheer volume we cannot handle because we don't have enough clinicians.
Yeah. So would that, what you were saying earlier, would that explain why a child can concentrate for hours on something they love, but not 20 minutes in school? Does that tell us? Yeah. Mm-hmm.
Yeah. So that basically they get more reward from that activity. That's tapping into their internal reward systems, as opposed to somebody from the outside talking about something they're mildly or moderately interested in. And what does ADHD look like when it isn't hyperactive? There's a different set of symptoms, is there? Yeah. So inattention looks like lack of motivation, lack of interest, lack of ability to make decisions, can't really start anything, starts loads of different tasks but completes none. You can hear the first part of an instruction to forget all the rest. So it causes a whole host of problems. And to people on the outset, unfortunately, it looks like they're lazy, that they can't be bothered to listen, that you're not important to them because you don't text them back. There's a load of those things going on that are being labeled as just bad behavior, but we got to understand that their brains have evolved to be different from what our expectations. If everybody was like that, it wouldn't be a problem because you'd expect people to be like that. It's a problem because we expect them not to be like that. So if everybody had ADHD, it wouldn't be a problem at all. In fact, it would be weird that you didn't expect them to be like that. So you could flip it on the other side and just, if you think of it like a variant of a normal brain that's just different, it's not really a disorder. It's just that it's a mismatch between the expectation and what people bring.
And what do you think the cost is of spending years believing or being told you're lazy or disorganised?
Psychological impairment. So it will ruin your confidence, your self-esteem. It could turn into these self-fulfilling prophecies where you stay back as opposed to engage because you think you're going to fail anyway. You might think that you were rubbish at things, that you just never gave yourself the chance to try. So it limits your life, literally. It will make you go for the lower end of jobs because you don't think that you would possibly be able to do the higher jobs. It will limit your relationships because you might not think that people are going to accept you or like you for the way that you are. So this is the biggest problem with being different, is that the majority population are going to treat you as if you're weird. And weird in human brains is a sign of you might be kicked out of our clan and you might die if you are. So that is a significant threat for human brains to see any sign of disapproval. So it could be your parent, it can be a friend's parent, it can be your friends, it can be your teachers. They will show signs of shock when you do something that they didn't anticipate that you would do. But immediately when the human brain sees that, it goes, oh, something's weird with me. And why aren't other people behaving or getting these reactions? Must be something wrong with me. So what happens is a psychological wound, unfortunately. And unless they get the context that it's not that you are inadequate, it's that you're different. You can perform and achieve exactly the same things if the conditions are right for you. So if you can change your day so that you go to school between 11 and 4 o'clock, as opposed to, 8 or 9 to whatever, 3 o'clock, then you would have half a chance to do better. But we don't do that. No, everybody has to go to school at exactly the same time, and they have to work in exactly the same hours. But with neurodiversity, so we're all on some sort of neurodiverse spectrum, there are differences in when brains are most alert and when they're not alert. And it would just make so much more sense to go with biology as opposed to have this generic, well, you have to be at work at 9 o'clock. We don't really care if your brain is active at 11 or not.
Do you think that we can't really accommodate? I mean, if we've got 1 in 5 people that has a special need now, it's not really special anymore, you could argue. Do you think we do need to adapt our schools and our education system because of it? And how would you do that? Because you can't suit everyone, presumably.
Of course you can't. But there should be a little bit more emphasis on finding balance. So at the moment, it suits our working rights that we work from X o'clock to X o'clock, but it doesn't suit individuals we're trying to train and educate. And it doesn't suit the employees we're trying to be more productive. So by having more kind of, learning or work types that are a bit more flexible could actually help a great deal if we weren't so rigid. But we're still very rigid. We still keep changing the clock every year, although most of us are no longer farming. So,
Yeah. What do you wish teachers and parents understood about this? Do you think they're missing something?
I think what I would really like them to be is curious and do not stick to their theory too much. So human brains are designed to create a narrative. That's normal. We all do that. We write a narrative, and then it's much easier for us to seek to confirm it as opposed to seek evidence to the opposite. So if teachers were having less of a confirmation bias, same with parents, if they were more curious about thinking the opposite as opposed to what confirms my suspicion, I think there would be better problem solvers.
So could you give an example?
Yes. So say that you have a child that genuinely has ADHD. perhaps hasn't been diagnosed yet, that really struggles in the morning. It's really easy to think of that as just being really lazy, just being a teenage boy. He just doesn't want to get up and wake up. So what we're going to do is try some harsh ways to get him to wake up. Yeah. Whereas I think if parents were just a bit more curious and they tried different things to learn about this child's behavior, I think they would realize that when he's left to his own devices and he wakes up and he's more happy and bright at 11 o'clock, that kind of tells you that his normal circadian rhythm is just different to your expectation. And actually the answer, instead of throwing water on his face to get him to wake up, would be to see if there's any reasonable adjustments that can be made or anything that can be rejigged. But with the current system that we have, it's not possible because everyone needs to attend at the same time. Obviously, there are advantages in that. And we have to exist within a system. We can't have a different system for everyone because it would cost too much in terms of resources. So a blended kind of learning would probably suit that student better.
Yeah. Makes sense. So let's move on to your technology, which is EIR. I don't know whether you want to tell us what that stands for, but what is the problem you're trying to solve with this and why?
It goes back to the point you made at the very beginning, which is that psychiatry is predominantly subjective. So think about what an ECG does for a cardiologist. So you go to the doctor.
When you say subjective, you're meaning it's their opinion. They look at their patient, they ask a load of questions, maybe fill in some forms or whatever, and they say, in my opinion, you have ADHD. And what you're trying to do, which we hope will be the future of this discipline, will be to have some kind of test. So so let's talk through that.
Yeah. So like an ECG is useful for a cardiologist, EEG can be useful for psychiatry because currently assessments are heavily subjective, which is right because it's a behavioral problem. So we have to look at the symptoms that we observe, but also we have to appreciate that underneath that behavior is a whole load of brain functioning. So brains are not modular. They have network activity, and certain psychiatric conditions have certain patterns in brain activity that we can detect and use EEG to look at. So
EEG, and what happens if I put the headset on? What's going on?
If you put on the headset, we will be able to see which parts of your brain activates how much. So we can see cortical activation, we can see arousal, and those things can tell us on the spectrum of neurophysiology what is going on beneath your symptoms. So it will not diagnose for you.
Brain. So but sort of boiling it down really simply, you're looking at the communication, the networks in the brain, what's lighting up, what's activated. That is what you're looking at with the headset.
So it doesn't light up per se. We can look at how fast different parts of your brain is, and the speed of certain brain regions are really important. So underactive brains have slower activity, and slower activity can, not always, correlate very well with noradrenaline and dopamine. And those are the two key neurotransmitters in ADHD. Higher, faster brain activation patterns, particularly in the frontal lobe, tends to correlate more with hyperarousal. So it's too much or too fast activity in an area where that's responsible for executive function. So the analogy here is the conductor of an orchestra. So if you have an efficient conductor, he can point to each a cognitive domain or system in the right order to get your brain organized and working well. Well, if you have a conductor that's not working very well, has too little energy, not the right amount of neurotransmitters, then that will be inefficient. So the network won't work well. That might mean that you will struggle with attention, with motivation, with energy, with arousal. And equally, if the conductor has far too much activity, you get problems with recklessness, with impulsivity, with inattention again, and other things that might look like ADHD, but then neurophysiologically quite different. So it is very complicated. EEG doesn't diagnose for you. It is objective insight that you use as an add-on. So what we are proposing with AIR isn't that you use this to diagnose. You use our system, which is a platform that integrates information. So it takes your clinical information that you already gathered, along with an EEG, which takes less than 10 minutes to record, and out comes a report with all the information that you already have, along with EEG, that will help you make better decisions. So it doesn't shorten the the assessment time. It'll still take however long it took before you used AIR, but what happens after the diagnosis now is different because you have more certainty when you make your decision. So an example is, with EEG, we can tell the difference between ADHD and anxiety with some certainty, but really it's the clinical information that makes the difference. It's the history taking. It's not, AIR can't diagnose for you. It is an add-on. It is something that helps you.
Software that measures this brain activity that can help identify whether you have a good orchestra conductor, a good person helping you with your organization skills and the rest, or not. So that headset is measuring that activity. And it's like, maybe, would you say it's like a blood test, which may pick up a marker, inflammation, a signal that there could be something more to look at. So you have it as a test that goes along with the view of a clinician. That's what you're saying?
Yeah. So we will show you tendencies. It will show you that this brain has too much fast activity, probably look more towards anxious disorders. If it's a brain that is slower in activity, it's probably a presentation that's more towards ADHD, but it's not that clear cut. It depends on the clinical information that you also supply, because I've certainly had ADHD patients that I'm convinced has ADHD, and I look at their brain and they don't have the pattern that I anticipate. So what I do with that isn't to say, oh, this is an ADHD. I say this is a patient with ADHD that wouldn't benefit from stimulants. Because if you add stimulants to somebody with high frontal beta, probably they're going to get a great deal worse, not better. They would benefit more from a non-stimulant. So EEG can be really helpful in getting it right from the beginning.
Yes. Yeah. So that's really interesting, because we could be over medicalizing or over prescribing to patients, and we don't really have a very good way of looking at how much dose or whether we should be giving drugs to children for this behavior. So you're suggesting that maybe in the future we might be able to use the headset to identify whether drugs would help them or not. That's what you're saying. Yeah.
Exactly. Yeah. And that applies to other conditions too. Like, we can detect when a bipolar brain is going into mania, or when a brain that is has a tendency to go into depression is entering depression. There are things with neurophysiology that will help clinically to make decisions about medication and treatment. And another example is, there are times where talking therapy is simply not going to work because the brain either doesn't have enough tokens, because it's way too anxious, or is way too depressed. And we can use EEG to tell the difference when therapy is more likely to have an effect. We can also see things like sleep deprivation and go in with interventions for that. So EEG can offer quite a lot of insights for clinicians. It just hasn't been available until AIR, because we have automated all the processes that has made EEG unavailable to clinicians that aren't neurophysiologists or neuroscientists.
So we'll just talk a little bit of science. AIR's the software. EEG is what? What is it doing? When you put the headset on, how does this measurement come about? It's not magnetic resonance imaging. It's not a scan. What's happening?
So it's measuring electrical activity from billions of cells. So it's taking an average of brain cells at every sort of, well, you can set it to take every millisecond if you want. Only academic scientists tend to have such high resolution. It depends on how many electrodes you have. So the headset that we use have 5 electrodes. And that tells us about how the prefrontal cortex is functioning, the temporal lobes, and then we got an electrode we can stick click on where we want. And that gives access to all the clinically relevant areas that I would want to see as a clinician when making these decisions. In academic science, you would have like swimming hat with 124 channels on it, which are channels all over the brain, and that gives you more resolution. But with EEG, it's not straightforward because it takes the summary, if you like, of billions of cells that's lying underneath it. So this position here will collect information from cells much further back as well because they average. So EEG isn't a straightforward technology, but we have been using it for a very long time, and there are many good correlates, but it can't be used on its own. It has to be used with clinical information.
So you've been using it for a long time, but you are going into trials. Is that you're, can you tell me more about that? What are they trying to prove?
In the first instance, we want psychiatrists to test it to see if they like it. In the second round, that will be the clinical validation trial. We are going to hand it over to an academic partner and they will test it. And what they will validate is that it is helpful and useful for giving suggestions to clinicians to think about. So it doesn't diagnose. A lot of people think that that's what we're trying to achieve. It doesn't do that, doesn't diagnose, make suggestions as to what all the information that you have is pointing towards, what to consider, what questions to ask, what assessments to take next.
What would be a report? Say we had someone who was showing brain activity of ADHD. What would you say that report would look like? I know it's not a diagnosis, but what would it?
It would summarize what it's found. So it will say on some of the questionnaires, it's scoring high on inattention, hyperactivity. Also on the EEG, you can see parts of the brain that are relevant, shows the particular marker that has been associated with ADHD. And in the consultation you did with the patient, they talked a lot about the history and the trajectory that is clinically significant and relevant for ADHD. It will pull that together in the summary and say, with all of these things consider ADHD as a diagnosis.
Okay, and what would make you say, I don't know how many people are in your trial, whether it's up and running yet. It's phase 1 trials, isn't it, involving humans, but what would make you say this has worked?
If we get data that is consistent across a certain amount of practitioners, psychiatrists, it will be psychiatrists in this trial, where their interpretation of the patient is consistent with the output. So if the output tends to lean more towards ADHD and the clinician agrees, not because of what the system said, but because that's the clinical input, that would be validation that it works for that particular purpose to assist clinicians in making diagnostics and treatment profiles for ADHD.
Yeah. Okay. So back to the idea that we're moving towards a sort of personalized psychiatry, because we'll be looking at an individual brain, and perhaps will that help us predict which treatments would work and which wouldn't, as we've discussed.
Exactly that. So it would just enable you to have more objective insight before you make your decision what this is and how to treat it.
So final question, it's really exciting. I was going to ask you, how many people are likely to be in your trial? Is there anything more concrete on that, or are you still planning?
We're still planning, but we're hoping to get at least 50 psychiatrists in that clinical trial.
Is it the first of its kind?
No, there are loads of trials like this, just not using our system.
Okay.
But we have to use our system.
Yeah, and how many children? Or
no children for this trial.
So psychiatrists looking at the scans of who?
Adults.
Adults. Okay, interesting. Yeah. So just, my final question. So if we're imagining sitting here in, I don't know, 2046 maybe, or 2036, do you think ADHD diagnosis and treatment will be different? And what is your hope for the future? What do you think we may be able to do that we can't do now?
I think we will develop more neuroscience technology to have more certainty. So EEG might play a role in that. We might come up with something better than EEG, something that is a bit more refined and has more certainty to it. I think we will have more nuance to the diagnosis itself. So I think there will probably be a differential between male and female, because the presentation for males and females are certainly different in ADHD. The criteria, I think, will be refined beyond just male, female. It will probably be more of an age refinement as well, because children present differently than adults. I hope people will be more curious as opposed to rigid about it. Not that I want more people diagnosed. I want more people to have an accurate diagnosis, because what happens when you're given a diagnosis that isn't correct is that you go through so much time internalizing a problem that probably has a better description. And internalizing a problem can lead to self-fulfilling prophecies, avoidance, not engaging where you should engage, lack of confidence, blaming personal successes or failures on something that you don't. So we need to get it right from the beginning, because it saves patients time and money, and it saves the system time and money. And overall, it would just be a better experience for everyone to have more certainty. So I think we are going to go towards more certainty.
Yeah.
Like the ECG for cardiologists, EEG could be that for psychiatrists, but it's a bit early to tell. We'll just have to wait and see.
Yeah, but your hope would be that this will be helping to give us a diagnosis and assessment and treatment in the future. Dr. Bernsten, thank you so much for joining us today. It's been absolutely fascinating. Thank you.